Thank you for the opportunity to present to you today guide catheter extension complications. These technologies come with a price, and so really trying to weigh the benefits versus the risk is pertinent in every device that we use in interventional cardiology. This is a traditional mother and child system where the extension system to the guide catheter gives additional backup support and also facilitates delivery of balloons and stents. And in my lifetime, this has really been the guideliner and the guidezilla, and I will use them interchangeably. To be clear, in my opinion, the guide catheter extension catheter is one of the top 5 advancements in interventional cardiology. It has really facilitated and made our lives easier and improved the safety of doing these procedures in our patients, increasing the success rates. The others, in my opinion, are transradial, PCI, physiology, IFR, FFR, Impella, aided high-risk PCI, as well as patients who are, I think, saved by Impella in some scenarios with STEMI. Certainly the CTO techniques and technology has advanced in my lifetime to being quite predictable and successful. And having been a fellow during the Cipher Taxus era, the deliverability of these third generation drug-eluting stents is quite amazing. We have all used the guideliner and guidezilla, I'm sure, because it's a requisite piece of equipment that improves our success rate for sure, no question about it. And it has this, flexible guide extension section that's, anywhere between 20 to 40 centimeters long now. There's a hypotube and there's a collar, and it allows us to extend our traditional guide catheter deeper into the coronary arteries, allowing us to be more successful. The original guideliner, as you see here, was quite simple in design, and it's amazing. It took a while to come to our daily use. We use this frequently when we need to deliver a stent distally within tortuous or calcified vessels. Failure to cross calcified lesions now can be conquered by the guideliner by advancing it, through the calcified lesion with different techniques. The inability to properly engage a guide catheter or be coaxial can be solved with a guideliner or guidezilla. You can distally deliver stents without injuring the proximal vessel by deep intubation of these extension guide catheters. You can do proximal to distal vessel stenting. The antegrade guideliner can facilitate retrograde techniques in CTOs. And you can get yourself out of tough situations like a trapped rotational burr, or also, in my case, 2 years ago at CVI, of a trapped balloon in a stent. The guideliner was definitely my savior. You can see here that in this particular study in India, where they used the guidezilla in 156 patients of 13,000 PCIs, that it facilitated success, and the failure rate was quite low, and it's because of probably extreme tortuosity angulation and calcification. And this particular series, complications from the guidezilla, was a dissection, a stent dislodgement, and shaft breakage. You can see this is corroborated in the FDA MAUD database, where you can report adverse events with devices. The 3 most common were catheter fracture of the guideliner / guidezilla, the inability to pass the PCI equipment or damage to the stent, and then coronary artery dissection. This is a classic picture of a radial approach, and you can see there in panel A on x-ray that the stent has been stripped off the stent balloon, and the balloon is distal to the stent. Panel B, you can see how the stent can get roughed up, and this is primarily due to the proximal collar. And this is just not a proximal problem, you can get the stent stuck on the distal edge of the guide liner or guidezilla also. Frequently, you can rough up the stent first, and then the inability to deliver it, you try and pull it back into the guide, and now there's interaction and you can strip off the stent. The transition zone of the first iteration of these devices have edges, and you can imagine with different physical angulations that the stent or the balloon might interact with this collar and cause some of these problems that we have seen. These are more stripped stents that can occur, and during the first iteration of these devices, I certainly saw issues like this. Here's something that the fellow was working on and really mangling that stent there. And the guide liner collar iterations was working to solve this problem. You can see here with the original metal collar, you can imagine the problems, and you can see this new polymer collar was an effort to try and decrease the edge effect or razor phenomena that can occur. Our current guide liner on the shelf here, the V3, has this kind of snowboard half pike that has some distance to it, leading into the circular portion of it that has really decreased the complications that we used to see. And that half pipe is about 17 centimeters long, and the rapid exchange now section is 25 centimeters. And this device, I must say, is a dramatic improvement over the first one, and these device interactions are a lot less common. The Guidezilla 2, to me, is pretty similar. They both have done similar things to minimize the device interaction. If you look at the specs between the two, they're pretty similar and not anything that jumps out to me as things that are different. Now, to avoid a dissection by using these guide extension catheters, you typically do not advance a guide liner bareback over an 014 wire. This razor effect can dissect the vessel. You should always advance it over a balloon shaft for more support. And then there's different techniques where if there's resistance to advancement, it can be overcome by inflating a balloon within the target lesion, followed by gentle traction on the balloon during advancement of the guide extension catheter to create an anchor effect, or inchworming is a common method that has gotten us out a lot of difficult situations. You should not inject via a dampened waveform or if the catheter is in a small vessel. And there's no reason for brute force with these catheters. Finesse should be the way. Now, this guide liner balloon assisted tracking technique you can see here is just taking within the guide liner a 2.0 balloon, inflating it partially, and then advancing it over the wire. And this creates a lot less razor or edge effects. The Blast G technique was really the inchworming technique, and Dr. Balakis has a wonderful short video that talks about this balloon assisted tracking, otherwise known as inchworming, where you basically take a 2.5 balloon, let's say 2.520, and wherever the guide liner is stuck, you advance the balloon, inflate it, and during the deflation, you can advance the guide liner over that deflating balloon. It self-centers and gets rid of these edges, and usually allows you to deliver the guide liner to where it needs to go, and you can do this inch by inch. The avoiding the PCI equipment damage issue was really solved mostly by the next iteration of the collar. But if there's still an issue, you can retract the collar out of, let's say, a tortuous segment, the innominate arch junction, for example, and then deliver the stent to minimize interaction. You can always introduce the stent into the guide extension catheter outside of the guide catheter, outside of the TUI, and then you can advance both together. You also need to be careful about avoiding wrapped wires, and you can watch the equipment as it goes through the proximal collar. So in conclusion, I would say the guide extension catheters are essential tools for the contemporary interventionalists, and most can't live without it. You shouldn't live without it. And new iterations have addressed most of the device collar complications, so this is seen much less frequently. And the tips and tricks with guide extension catheters, guide liners slash guidezillas are essential to becoming a 5-star interventionalist that we all want to be. Thank you. And if you have any questions, feel free to email me. And I look forward to seeing you in Denver next year.